Good morning to everybody. I've been given a difficult topic because I'm supposed to talk about carfilzomib in combination with lenalidomide and dexamethasone, and the data which are available are rather limited, also highly interesting. So I'd like to move forward. What is this? It overcomes bortezomib resistance. I'll show you a slide about that. And it has a short half-life, so this is serum half-life. It's less than 60 minutes. And what is important also for patients who present with renal impairment, there's no difference in patients with renal impairment. These are patients on dialysis. So, of course, the metabolism is independent of renal function. What you see is when you administer bortezomib, you get a very strong inhibition of the proteasome, but there is recovery here on the one, so there is rapid recovery of the proteasome function. So this is one of the, I think, reasons why dosing it on day 1 and 2 seems to be very efficacious. Now, it has been shown that the activity is significant. It's significantly greater than the activity of bortezomib, which is shown here, particularly on bone marrow cells, on blood cells. And it seems to be active and that is already shown in vitro, in patients in primary myeloma cells from patients which have been found to be refractory to bortezomib. So here you have again the activity of carfilzomib, which is active in those patients as well. Now this is a slide I've taken from Keith Stewart because he likes to present the activity of different anti-myeloma drugs in this way. And when we look at this cartoon, we find that the combination partners I'm supposed to talk about here, it's carfilzomib, it's dexamethasone, and it is lenalidomide. And of course, combining lenalidomide with dexamethasone is a good idea, and combining a proteasome inhibitor is a good idea. So you need the dexamethasone, and both the IMiD and the proteasome inhibitor make a very good couple. Now, which data are available? So when you look at this slide, you see the data which are available are rather limited. You've heard the data from Jakubowiak with CRD in patients with relapsed and refractory myeloma, and I show you more data here in more detail. There's a combination between varinostat and CRD, which is tested in the phase 2 trial. There are no data available, and we would have loved to hear more data about the combination CRD versus LD this is a phase 3 trial in relapsed and refractory patients. I will show you a slide later on. There's an interesting small study which has been presented by Ola during the last ASH meeting. I'll show you some data in smoldering multiple myeloma. And there are studies ongoing in patients which have not been previously treated, in newly diagnosed patients with CRD. There is some data available from Ola again in newly diagnosed patients. And Andrew has a study where he plans to use CRD before and after stem cell transplantation in order to maximize treatment outcome. There's a study ongoing combining clarithromycin with CRD, and there's a study planned or ongoing in US, pioneered by Shaji Kumar, comparing CRD with bortezomib, Revlimid, dexamethasone. Of course, there are no data at the time being available. Now, this is the treatment schema which has been used by Andrew in patients with with newly diagnosed myelomas. So this is the induction cycle. Patients who are not eligible for transplant are scheduled for 8 induction cycles. Those who are eligible for transplant and go to transplant have 4 cycles and then are continued. And here you see the dose. The first dose at cycle 1 is 20 milligram, and then the dose is escalated to 27 and 36 milligrams. This is the usual regime: lenalidomide conventional dose, dexamethasone conventional dose, but at cycles 5 and 8, the dexamethasone dose is reduced, and that is kept constant until cycle 24. And after cycle 24, patients are allowed to continue on lenalidomide maintenance therapy. What are the response data? The responses are really remarkable and impressive. So there is an overall response rate after 4 cycles of 100%. And then when you look at stringent complete response, it is already 45% after cycle 4 and goes up to 62% after 12 cycles. So there's a very high rate of stringent complete remissions in this patient group. And you see that the responses occur quite fast. When you look at the kinetics of the M protein, you see even on day 15 of cycle 1, a significant reduction in the M protein, and this continues, of course. So it acts in all patients, and it acts very fast, at least in this patient series. So when you look at response rates in relation to dose, the 27 milligram dose is working quite well. It's active in patients with advanced stage as well as in those with, of course, lower stage. But what is important, which is really important, when you look at patients with unfavorable cytogenetics, you see a very high response rate. So it seems to have, at least when it comes to response rate, it overcomes the negative impact of poor risk cytogenetics. This refers to response rate. Progression-free survival looks very appealing, very good. And when you look at the adverse events in more detail, these are the grades 3 and 4 adverse events. You see not many adverse events of major concern. Of course, there is hematologic toxicity as shown here. In this slide, there is actually infection rate of 23% of grade 1 and 2, which is important. There is little grade 1 and 2 neuropathy. There's no grade 3 and 4 neuropathy. There's a little bit of dyspnea. But in this slide, there is no mention of cardiac toxicity. So that is important to note because there's a discussion whether carfilzomib has some cardiac toxicity. And this study has been updated during the last ASH meeting. And so you see here data after longer follow-up, 33 months. You see a median of 24 cycles have been administered to the patients, range 22 to 24. Progression-free survival rate at 3 years is close to 80%, and overall survival rate at 3 years, 96%. At 3 years, overall survival rate, 96%, close to 100%. But then when you look at patients with poor risk and standard cytogenetics, you see there is a slight difference. So the poor risk patients have a slightly lower progression-free survival rate, a slightly lower overall survival rate, slightly lower CR rate, slightly lower stringent CR rates. So here, poor risk cytogenetics still matter. And then, of course, if you achieve a stringent complete remission, you are well off. Progression-free survival and overall survival is certainly much better. And when you look at the progression-free and overall survival rate in those patients who achieved a minimal residual disease negativity, you see excellent results, but you see some relapses in those patients which have been deemed at least one point during the follow-up to be minimal residual disease negative. So it's not, so it is, of course, can be associated with later relapses. So from Ola Landgren's group, this trial has been presented at ASH. So it is a study in newly diagnosed patients, actually 43 patients, I'll show you the patient characteristics in a minute, have been enrolled. So the treatment regimen is shown here, 28 cycles of CRT using this combination, followed by 24 cycles of Revlimid extending dosing without dexamethasone, which is important at a low dose of Revlimid of 10 milligram. Each cycle is 28 days. And patients, of course, who were fit for transplant were allowed to go to transplant. Yep. So this is the patient characteristics, a younger patient cohort. And the number of cycles which have been administered at the time of presentation were 12. The follow-up was 12 months. And this shows you the response rate and the time to response. Again, complete response, stringent complete response, 51%. After more than 8 cycles, it was 22%, but it increased with increasing of treatment duration. Time to complete response was very short, and progression-free survival at 12 months and 18 months is shown here. So here you see the graph. Again, you have seen this before, very rapid response of the M protein. So there's a significant fall in the M protein within the first cycle, and this remains, of course, and goes down further. So the number of patients with complete response after cycle 2 was 16%, and you see here a steady increase in those patients with complete response. These are near complete responses, and stringent complete responses goes up to 67%. Complete, near complete, or stringent responses in this patient cohort after 8 cycles, and these are the patients with very good partial response and those with the PR, but there are few patients with stable disease still in this patient cohort. Toxicities. Here you see in this study, you see some cardiac toxicity, but it's It's grade 3 and 4. This is a low rate, 9%. But it's a combination of hypertension and heart failure. There is some dyspnea in some patients, and electrolyte disturbances have been shown in 2 out of 10 patients. As you see here, there is a low infection rate. VTE have been seen in 7% of patients. And of course, there is significant hematotoxicity, but this refers to lymphopenia, so there is a risk for reactivation of viral infections. And of course, anemia, neutropenia, and thrombocytopenia are seen in about 20 to 30% of the patients. These were newly diagnosed patients. And this is an interesting study. Has been presented at ASH again. Maybe some of you or many of you may have listened to this study. This is the same treatment protocol as was used in the previous study, but the patient population is completely different. These are high-risk smoldering multiple myeloma patients. And the primary endpoint of this study is response rate. Secondary endpoints are shown here. This study is conducted with several additional investigations, MRD, clinical biomarkers, PET scan, and so on. So what is the value of this treatment approach? So as you know, there are 2 models which are available to categorize your patients with smoldering myeloma as low risk, intermediate risk, and high risk. So there is a Mayo model, which is straightforward. Patients must have more than 10% plasma cells and protein more than 3 gram free light chain ratio must be abnormal. So if you have all of these 3 parameters, you are a high-risk smoldering myeloma patient. So you have a 5-year progression rate of 76%. If you have only one of these features, your 5-year progression rate is only 25%. The Spanish group uses the relationship between clonal plasma cells and normal plasma cells. So they do flow in older patients, and if you have more, 95% of clonal plasma cells and only 5% or less than 5% of polyclonal plasma cells, you are a high-risk patient. And another factor was immunoparesis. So if you have clonal plasma cells more than 95% and immunoparesis, you qualify as high-risk patient. You have a 5-year progression risk of 72%. This looks pretty nice because this is comparable. The risk for progression in the high-risk categories, either in the Spanish or in the Mayo model, is similar. So what is the problem with these 2 models? There's a significant problem, I think, because when you compare these models in a patient set, and this has been done by Ola Landgren's group, he compared both models in 77 smoldering myeloma patients. And what you see here is that there is very little agreement. There is only agreement in 22 of these 77 patients when you use both models in the same patient population. So probably so each model depicts other patients who are at high risk for progression. And you can look at these data in a different way. You see here there's a discrepancy of both models. So the question is, shall we use both models in order to identify patients with high risk for transformation, or shall we use either one of these models? So this is a big question in these days. Now, what did he achieve? At ASH, he had only 12 patients he presented on. These were 12 patients with smoldering myeloma. 11 met the criteria as issued by the PTEMA group, by the Spanish group, and 1 patient met the criteria for both the PTEMA and Mayo model. And protein level was quite low. And now you see the response data. After 8 cycles of CRT, all patients responded, everybody responded, and you see 92%, so 11 of the 12 patients are MRD negative at the time of investigation, and the median time to CR or stringent CR was 5 cycles. So this works very well in this group of patients. Again, you see here's a rapid fall in the M protein, and this fall, of course, can be maintained during treatment in most patients. What were the toxicities? They are listed here. Not so much. Rash, this is grade 3. This is a non-hematological toxicities. Again, cardiac heart failure, I'm sorry, this should read 8. So one patient had cardiac dysfunction, liver function evaluation. So it's very little non-hematological toxicity, and this is the hematological toxicity. So again, lymphopenia was prominent, and then anemia. So, so these were the smoldering multiple myeloma patients, and these studies are highly interesting. This study is a large phase 3 study in patients with relapsed refractory multiple myeloma, and it compares CRD with RD. And actually, this study is now very mature, and actually it was expected that results will be disclosed in the next few months. But I think what I've heard is it will take longer until we get these data presented. Keith Stewart is the first author, and so we will probably have to wait until ASH in order to have the data disclosed of this very interesting phase 3 trial comparing CRD with LD. And with that saying, I would like to close. So I think carfilzomib has to go with dexamethasone. We know this from the FOCUS trial. So in FOCUS, carfilzomib was used as single-agent treatment. So it should be used together with dexamethasone, in my opinion. Of course, lenalidomide is an excellent combination partner. You can think about thalidomide, and there's a study from Peter Sonnefeld in relapsed refractory, in newly diagnosed patients with this combination. You can think about the combination using pomalidomide. You can, of course, use melphalan. Cyclophosphamide has been used by Antonio Balomba. This triple combination with very good response rates in newly diagnosed patients. Bendamustine may be a combination partner. Daratumumab, of course, all antibodies which show activity, may be excellent combination partners. Doxorubicin is not my favorite, but you can think about that. And of course, there are many others you can think about. But I think a 3-drug regimen is still the way to go until we have more data showing that adding a 4th drug is beneficial to our patients. With that saying, I would like to stop here. Thank you for your attention.